I'm pleased to welcome Dr. Tasmeen Weik. Dr. Weik is currently a health scientist with the Office of Population Affairs within the Office of the Assistant Secretary for Health. In her current position, she leads OPA's effort on the Affordable Care Act, manages a portfolio of reproductive health research, and works on performance measure development and other reproductive health data projects. Prior to starting with OPA, Dr. Weik was with HRSA's Maternal and Child Health Bureau for almost 3 years as a Director of Research for Emergency Medical Services for Children program. Prior to that, she was with the Children's National Medical Center for 11 years with the last position as the Executive Director within the Child Health Advocacy Institute. She has been a HRSA grantee and contractor and has 15 years of experience in public health and policy. She has specific content expertise in pediatric emergency medicine, emergency medical services, disaster preparedness, and reproductive health. She has significant experience in performance measure development and implementation, evidence-based guideline development, training, and stakeholder engagement and management. And with that, I'd like to welcome Dr. Weik. Dr. Weik?
Thank you so much for having me on the call today. So as was mentioned, my role at the Office of Population Affairs is to really help our network of family planning centers think about how they may be able to be sustainable in the new healthcare environment. As many of you know, the health system has already changed as a result of the Affordable Care Act. So for my talk today, I'm going to provide you with a very broad framework for sustainability of family planning centers generally, and some specific tools and metrics you can consider to look at your own programs. My talk will not be specific to LARCs, but many of the things that I will talk about, particularly the metrics, can be used for your LARC-specific programs. But again, I'm going to provide you with kind of the 50,000-foot view of some things you need to consider in terms of financial sustainability generally. So I'll start out by just giving you a big framework of what we at the Office of Population Affairs have communicated to our Title X family planning centers in terms of what the ACA means for family planning. In general, again, as many of you know, with more individuals covered for insurance through the health insurance marketplaces, you're going to have a greater number of clients who are insured, particularly clients who are insured for contraceptive services. But those clients need to come to centers that have contracts with private health plans so that they are considered in-network providers. So one of the key messages we've sent is that you really need to have contracts with private health plans. We also know that in order to have those contracts with private health plans, you need to have investments in health information technology so that you can provide health issuers with information on patient care quality, as well as be set up with things like electronic claims processing. So centers also need to have some level of investment in electronic health systems, as well as other kind of administrative systems to manage health information. We also know that a number of family planning clients will now qualify for health insurance through Medicaid expansions, and that again, the more that centers can help their clients get enrolled into those health insurance programs that they qualify for, the greater the chances of them getting reimbursement for services they already provide, like LARCs, like contraception. And then lastly, again, we know that 6 out of 10 women access family planning as their usual source of care. And so we anticipate that, again, as more women in particular receive coverage through health insurance, they will come to their usual source of care expecting more than just family planning visits. So we have encouraged, again, our Title X centers to consider expanding services to include more primary care, or more significantly partnering with primary care providers. So in terms of financial sustainability, where do we need to go? The poster I'm showing you now is, again, something that we've developed for the Title X network, but is really applicable to many different types of centers. in terms of what you need to do in order to be sustainable. So I talked about a larger framework. These are some sort of very specific metrics that you can use. If you look across the bottom of this chart, you'll see some of the categories of activities, like looking at patient experience, clinical quality, electronic health records, etc. And then if you read the chart from bottom to top, going from light blue to dark blue, the light blue side are what we consider unsustainable practices, and then the dark blue is where you want to work towards. So you want to work upwards towards more leading edge practices. So to give you one example, under revenue cycle management, if you're not currently billing third-party payers, that's considered an unsustainable practice, whereas kind of moving more towards the leading edge, we recommend that you be monitoring your billing systems, looking at performance, looking at specific financial indicators, and I'll talk more about what some of those indicators could be. So take a look at your own clinical center, and just as an activity, mark the kind of area where you are at in each of these categories. And if you're more towards the sustainable and leading edge side, that's great. If you're not, then this also helps give you kind of a direction that you can move towards. So one of the things that our office has developed to again help centers look at their sustainability is what we're calling a sustainability assessment. We have a service site tool that a health center can use to look at where they are across all of those indicators that I just talked about. So it has questions around what you're doing related to enrollment, how you're partnering with primary care. It has some very specific questions about EHR systems and how you're using your EHR systems for quality monitoring and improvement. We have a few questions around revenue and what you are looking at in terms of your financial metrics, and then some questions around contracting with health plans and cost analysis. This is a tool that I've shared with ASTHO, and you are welcome to use it. It's very much in draft form, and we're continuing to develop it, but it is one way to survey the sites that you work with to get a deeper understanding of where they are, again, when thinking about overall sustainability. So now I'm going to get into some kind of specific metrics, and I'm not going to talk about every single financial metric that you should be following, but I've pulled out a few that may be particularly relevant to those of you that are looking at your LARC reimbursements. So the first and we call these key performance indicators, or KPI. So the first key performance indicator, KPI, that I want to talk about is the gross collection rate. The gross collection rate tells you what percentage of total charges are collectible with respect to insurance contracts and patient mix. It looks at the charges submitted against the collections with no consideration as to what the expected payment is. Now, over a period of time, this should be between 40 and 60%. And again, it helps you look at your utilization and your payer mix. So as I mentioned, over time it should look between 40 to 60%. Below 40% means there's a problem with your collections process. So although it's a general calculation, too low may indicate that that your collection process needs to be improved. But also a too high rate isn't that great. So if it's over 75%, it may indicate that your prices are a little bit too low. And a stable gross collection rate within that 40 to 60% are acceptable parameters, and is a good indicator of billing and your collections effectiveness. So the next one I will talk about is your utilization. So utilization helps sort of reflect how busy the clinic is. It's typically the number of unduplicated patients, and utilization should be tracked over time. So, and your benchmarks can vary very much by site, and in fact one of the ways that you can use utilization is for purposes of strategic planning, to figure out where you would like to see your utilization rates go and help you kind of develop goals. So the next one is your payer mix. And the payer mix is the percentage of a clinic's kind of annual revenue that's comprised of each revenue source, like Medicaid, Medicare, commercial insurance, those that are kind of self-pay clients. For Title X clinics, it's the clients that may be on a sliding fee scale. So each payer generates a specific income that can identify kind of which payer is bringing the highest proportionate of revenue. A diverse payer mix is really critical for maintaining financial health, and we really recommend that you diversify your payer sources to make sure that you have some stability and to protect your financial health. So the payer, you'll see on the right-hand side of this slide here that we've shown you sort of some graphs. So you can see where you can use this as a bit of a dashboard for your own clinics. Your payer mix information can help you sort of with some strategic planning and help you add or modify insurance contracts. Some low revenues in kind of the private insurance side may tell you that you need to try and get more commercial contracts, or you may need to do some outreach to see if you can get more of those private insurance clients. Now there's not really an ideal payer mix that applies to all clinics. It really depends on your type of clinic. In Title X, for example, the biggest payer is Medicaid, and that is quite appropriate because we serve a low-income population. So it really just depends on your clinic demographic, but again, having these and benchmarking them can help you track your payer mixes over time. And again, the key is to make sure that you do have some diversity to ensure kind of long-term financial health. The next one I'll talk about is net program revenue. Net program revenue is simply the total revenue from a program less all program-specific expenses. So again, you can see how you can tailor this to just your LARC program. You can look at total revenue just from your LARC program minus all of the program-specific expenses. You want to compare your net program revenue to your budget to again look at your financial health and determine whether the program is on pace to meet your long-term objectives. It's very common to vary from your budget. A budget is simply a planning tool. So on a monthly basis you'll see some perpetual variance. Depending on how much the clinic is utilizing, your funding stream, or if you have high expenses in a particular month, say you go ahead and pre-purchase a number of LARCs in a particular month. So ultimately the goal is really to just be within the budget by the end of the year. Most companies, if you look at the private sector, will set kind of an acceptable tolerance level for variances from actual to budget as plus or minus 5 to 10%. So if you see a consistent variance in excess of 15%, that's when you may want to take a little bit of a closer look to make sure that you don't get to the end of the year and notice that, that there is a big problem. So in kind of finishing up, I want to point you to a few resources that are available from the Title X National Training Centers. We have a number of trainings that are available specific to LARC, clinical trainings that are accessible to anyone and everyone for free. We also have a training specifically on cost analysis. This is an online training and you may be particularly interested in it because it helps you understand your fee schedule. So if you are in the group of people whose gross collection rates are pretty high and you're debating whether your fees are too low, a cost analysis may help you figure out how best to handle that. We also have a number of webinars on revenue cycle management that talk about everything from how to diversify your payer mixes and contracting with private health plans. We have a 3-unit coding e-learning module that is for clinicians to learn how to code for family planning visits. And then we have a number of resources on outreach and enrollment, again if you need to help get your clients enrolled into affordable health insurance programs. And then what I have just shared with you in this talk is a financial dashboard or pieces of a financial dashboard that we will be creating and putting up on the Training Center website. And that website is www.fpntc.org. So I've just shared snippets with you, but we will be building this out as a full financial dashboard that, again, you would have a way to access. So with that, I'll see if there are any questions.
Thank you, Dr. Weik. While we're waiting for questions to come into our chat box in the bottom right-hand corner, I would just like to say that like Title X, like what we're seeing in state Title Xs, Medicaid is also the #1 payer for immediate postpartum LARCs in hospital because all of the states involved here have been working very hard to get those policies in place and maybe not have had the same successes within private. So I can see this dashboard being really helpful for tracking that private spending over time and seeing if the revenue there has increased for paying for LARCs immediately postpartum. So thank you. We do have a question in the chat box, and that's a lot of these measures were specifically for Title X clinics, and so can you discuss what might be some changes that we'd need to do to adapt the financial dashboard to LARCs in hospitals, and maybe what kind of data we might need or how we might go about doing that?
Sure. So I think one of the things you could do is to look at your payer mixes. A lot of the references that I gave you, and they're on my slides, are really from the general health literature. And so they're not as Title X specific, even though this was developed for Title X. So for example, the annual gross collections rate that I talked about with 40 to 60% being a general benchmark is not specific to Title X. It's actually just specific to the general kind of accounts receivable benchmark that the Medical Group Management Association, MGMA, released in August of last year. So I think much of what I talked about is fully applicable to multiple different settings. Where there might be differences are things like how much of your revenue comes from Medicaid versus from other sources. And as I mentioned, that really is dependent on what the type of clientele that your clinic serves, and the amount that you may be able to vary your payer mix will also really depend upon the type of clients that your clinic serves. The other thing, when you look at your net program revenue, LARCs are very expensive, and depending on who you're serving and what your reimbursement sources are, you may have a budget for LARC that exceeds what you collect in program revenue, which is not something that any benchmarking source will tell you is a good thing. But again, it depends on the clientele that you serve and whether you have grant revenue and other types of revenue that help defray some of those costs. So all of this has to be sort of customized to the setting in which you're working. If you are a health department, then you may have a different mandate than if you are a private hospital in terms of who you serve and what your payer mixes look like.
Thanks, Dr. Weik. We did get another question in, and that was around many of the states. And in our polling, we found out that most people in the learning community either aren't the ones responsible for or aren't the ones in charge of doing these financial performance reports. And so the question is either how can they get assistance with working with the right people to figure those questions out, or through the system that you mentioned previously, the technical assistance, how can they get assistance with setting up those dashboards?
Sure. So that's a really important point. In many organizations, but also particularly in health departments, it's a large department, and there may be an entire division or sub-department that is dedicated to looking at these financial metrics, and in many cases a program office may not even have access to this information. So the first step is to find out who in your organization has access to this information. Somebody that looks at the kind of financial data coming in has access to it. They may not be looking at things specifically to family planning, or they may not be looking at specifically what your reimbursement rates are for LARC or what your payer mixes are for LARC. So it becomes even more important that you go find that department or person who has access to this information and ask them for the data that you're specifically interested in. The dashboards that I showed you are not yet available on the FPNTC website, but we hope that in the next few months they will be. So the way the dashboards are set up as Excel files, so that if you have the data you can just plug it in and it will create those beautiful charts that I showed you. So do check back on the FPNTC website. So unfortunately that's the only assistance that OPA is able to provide right now. But again, the key thing is to go find that individual in your organization that has access to this information and to look at the data yourself. These calculations are not that difficult once you have the data, but getting the data is a bit of a hurdle that you'll have to figure out.
Thank you. And ASTHO will certainly let everybody on the call know when those charts are available, and we can follow back up with Tasmeen or the center to see if we can get additional assistance and maybe do a technical assistance on using those. With that, I'd like to thank you, Dr. Weik, for your presentation, and we will continue with the next portion of our learning community.